Welcome to Ask Sid, the official podcast for Sydenham Clinic, a clinic where luxury meets medicine. We are on a quest for longevity. And I am so thrilled to be your host on this show. My name is Aanchal. I am the founder and CEO of Sydenham Clinic and the author of Your Doctor Is Not God and How to Be the CEO of Your Health. I look forward to taking this journey with all of you and having amazing thought leaders, guests, and members of our Sydenham team answering questions that you put forward. And I urge you, and I hope you will, ask Sid more questions on longevity, wellness, living to your highest potential. We are all trying to be the best versions of ourselves, and our physical, emotional, and mental health is foundational for us to achieve health and success in other realms of our life. So welcome to Ask Sid. Welcome back to Ask Sid. And today's topic is making waves with all these celebrities using these new age weight loss drugs. What initially started as diabetic treatment has now recently got approved for weight loss. Zeptide, the latest drug, just last week got announced that you can use it for weight loss. So we're here with our very own Dr. Terry Rice. Dr. Rice is the medical director. She's the creator of the whole Sydenham method. And I think you all know her, but just in case, I will introduce her again. She is an internal medicine physician. She was heading the emergency department at MD Anderson. She's got decades of experience with traditional medicine, and she's going to talk about why she believes in personalized medicine and the Sydenham methodology. And this is how she had experience with all these new age drugs with your patients. And we want to really dive deep on your anecdotal personal experience as well as your professional expertise on explain to us, like, what are these new age drugs? Like, what's happening? This is going to become $100 billion industry by 2050. Mm-hmm. This is a big change in medicine, right? In your lifetime that you've seen?
Yes, this is a big change. And I think it is really exciting because as everyone knows, in the developed world, obesity is becoming a real huge health problem. And we are experiencing an obesity epidemic in our country and a lot of other countries as well. Yeah. As a matter of fact, since 2018, the number of states that have been designated as having an obesity epidemic, over 35% of the adults being overweight or obese, has doubled just in the last 4 years. So this is becoming a very large problem in our country and around the world. And these medications seem to be one of the first really successful tools that we've had to help people with their weight gain.
So what are these different, like, what's the difference between a Mounjaro and an Ozempic and a Wegovy? Can you just dive deep into what these medications actually are? Because some of us may have heard the names and they've become like popular cocktail party discussions, but let's inform our listeners as to what these medications actually are.
Okay. Well, there are three main players in this market, and they are peptides, which means that they are just small protein molecules. And the first one was liraglutide, which was known as Victoza, and Saxenda. The second one, one we hear more about now, is semaglutide, which is Ozempic and Wegovy. So many people don't realize, but Ozempic and Wegovy are the exact same medication. They're just packaged differently for different indications. And then the more recent player on the market is tirzepatide, which is Mounjaro. And Mounjaro just became approved for weight loss. So initially, all of these medications were brought to market for the treatment of diabetes. And then it was found that the patients taking these medications were losing weight. And so subsequently, semaglutide, which is Ozempic, became approved for weight loss and was marketed under the name of Wegovy. And then, as you said, last week, tirzepatide, which we know is Mounjaro for diabetes, was FDA approved. Of course, it's not available yet for weight loss, and that'll be known as Zepbound. So how these drugs work is they're very small molecules, and they actually stimulate the brain. And they stimulate the brain to do a few different things. So they work in many areas, but one of the main things that they do for weight loss is that they stimulate the brain to feel that it's full and to slow the stomach's movement. So the food that you consume stays in your stomach longer and you feel full longer. That's one of the effects. They also have effects on the liver to reduce the amount of glucose or sugar that's produced by the liver, and then they have an effect on the pancreas to increase the amount of insulin made by the pancreas. So Ozempic, semaglutide, was a once a week injection, and it is a GLP-1 agonist. And what I just described is what it does, okay? So it slows your gastric emptying and it makes you feel full. I don't think we know for sure if it's just the slowed gastric emptying or if it's also the stimulation of the brain to make you feel full. I think it's a combination of those things. So people find it much easier to eat smaller amounts and not to eat as frequently. They talk about reduced cravings, and they frequently talk about actually less alcohol consumption as well. Mounjaro, or tirzepatide, is slightly different because it's a combination of a GLP-1 agonist and a GIP agonist. So for the most part, the effects are the same, except for with this difference. So the tirzepatide, or Mounjaro, does not slow gastric emptying, the emptying of the stomach, as much as the semaglutide or Ozempic does. So it has decreased gastric emptying, but it's about 50%. So an equivalent dose of each of those two medications, the second one, the Mounjaro, would have only 50% as much action on emptying the stomach or reducing the emptying of the stomach, but it has more activity in the small intestine. But it also makes you feel full. And so this is how it's really causing an incredible breakthrough in weight loss.
So in your practice, when you prescribe these to your patients, I know you personalize, which one would work better for which person. So like, does it depend on the side effects? Does it depend on individual tolerances? Like what are the different reasons why you would personalize which weight loss drug or which, for diabetes, I mean, whatever you're using it for?
Right. So these drugs are FDA approved for pre-diabetics. And so I and the clinic here, we're a big believer in treating someone when they're heading into diabetes instead of waiting until they're a diabetic, because of course diabetes is very dangerous for your health. And when you reach that stage, that means your pancreas is really being stressed. It's no longer able to keep up with all the insulin it needs to produce. So by that point, you're already entering a stage where damage is being done to your body. So the idea is to prevent that from happening, right? So in my patients, I would say that a lot of this has to do with, first of all, what medication will be covered by their insurance, what medication is accessible based on their diagnoses, and then also on personal preference. But it seems that the tirzepatide, or Mounjaro, the more recent drug, has less side effects than the Ozempic. Because it doesn't slow the gastric emptying as much, people don't have as many problems with reflux, heartburn, feeling full, nausea. So those are some of the symptoms that are bothersome, and certainly more bothersome in semaglutide, Ozempic.
So can you share some of the success stories you've had? Because clearly, you were one of the early adopters in the country. I mean, you have over 3 years of experience with these drugs, right? There was a pill that first came out, right?
So the first one was liraglutide, and that was called Saxenda Victoza, and it was a once-a-day injection.
Right.
And then semaglutide, so they'll have all these different names, also known as Ozempic. That's what everyone knows about, right? Yeah. Then approved for weight loss as Wegovy. It was also put out in a pill called Rybelsus.
Yes, that's right.
Yeah.
So In your like experience, where you were the early adopter, like what are some of the success stories you've had? Like, I know a lot of things are written and people can Google the research that's available on these medications, but anecdotally, like what is your personal experience been with these? If you can like give us some case studies or some success stories, experiences.
Well, you know, I think it's really difficult for people today that have problems with weight. And there's a lot of shaming, I think, involved in that, or just this idea that if you would just eat less and exercise more, that you could get your weight under control, you know? That it's kind of like your fault. But there's really a lot of other factors at play. I mean, there's a lot to do with the food that's available to us, our lifestyle, the comfort crisis, the fact that, you know, everything is temperature controlled, people have difficulty with sleep. There's a lot of reasons nowadays why people have problems with obesity. And once you gain a certain amount of weight, the mountain that you have to climb to get it down and to reverse things like insulin resistance is really, really difficult and insurmountable for many people. I think what many people don't understand is that humans evolved through a lot of starvation, and we are uniquely adapted to put on weight and to prevent starvation. So this is a big issue for us. And one of the things that happens in the human body is that when we are overnourished and then we store this overnourishment, be it carbohydrates, fats, protein, whatever, we eventually store it as fat. Once we store it as fat, then our body increases the insulin production because it's trying to push the glucose into the cells, and it makes more and more insulin to do that. And once your insulin levels go up, your cells will not release the fat that's in them. It seems like a crazy situation, but I think it has to do with our ancestry, and that when your insulin levels were high, that meant you were eating and consuming, so that wasn't a time to release your fat. You should save your fat for later on when you're starving.
Winter's coming.
Right, winter's coming. Save your fat for when you're starving. Don't burn your fat when you have high insulin levels, because high insulin levels mean you're consuming, okay? So we get in this situation where people are overweight, their insulin levels are high because they've been overnourished, they're insulin resistant, and they can't get their cells to open up and release that fat because the insulin levels are stuck at a high level. So these medications seem to break that cycle. And I mean, I have multiple patients, it's just life-changing. It's just, you know, when you see a woman come in and she's in her early 40s and she's just crying because she's done everything she can and she cannot lose weight. And it's not 5 or 10 pounds we're talking about, it's 40, 50 pounds. It's just a very, very difficult situation. And these drugs seem to really break that cycle. And I have, you know, multiple patients. It's changed their life. It's changed the way they feel about themselves. They've been able to buy all new clothes. They are able to exercise again. They have confidence again. They've returned to the way they see themselves before things got out of control with the whole weight loss just snowball thing, or weight gain snowball thing.
Yeah, and I mean, look at the importance of mental health, right? The effect of your confidence, feeling good, feeling fit on your mental health is immense too. So I think this is going to have a ripple effect on overall health, happiness, longevity.
Yeah.
And, you know, at Sydenham, I know our approach is 7-pronged, where we start with genomics, right?
Right.
Do you think they should like make this available to people who have, like, I have all the fat genes possible, right?
Yeah, so do I. So do I.
Can you talk a little bit about fat genes and maybe like, you know, what is the role and the connection of these drugs for maybe people who have fat genes?
Well, on the genomic analysis we do, I guess there's about 20 different genes that we look at. We look at what's called SNPs, minor variations in your genetic code. And some of the most important genes for weight loss or for obesity are called the STAT3 genes. And we look at 4 or 5 of them. And basically what the STAT3 genes do is they make you sensitive to saturated fat. So this is all animal fat, poultry fat, and of course dairy, right? And again, this is thought to be an ancestral gene for survival. And the idea was that when you killed a big animal, that eating the animal and eating the fat of the animal actually stimulated your appetite so you could gorge yourself so you could eat more for the hard times that were going to come. Okay? So these genes are very strong and very important. And if you get 2 copies of them, then in multiple, so you have 5 possible genes, and then you can get a copy from each of your parents that says you're sensitive to saturated fat. That's a really important thing to know with the patient, because you can sit down with them and go, look, you need to really eat lean protein, and you need to use unsaturated fats like olive oil and avocado oil, but your protein needs to be lean. You're not a person who should be eating the fat off the skin or the fat on the pork or the beef or whatever. So, and there have been studies that have shown that this is directly, that saturated fat intake in people that carry these genes is directly related to abdominal girth. They tend to put it on the middle. Then there's another set of genes called the FTO genes, very similar. Increased risk of diabetes, adult onset diabetes, type 2 as we call it. Increased sensitivity to saturated fats that literally stimulate your appetite. But also the good thing about the FTO genes is that people that have them, they can regulate those genes better with exercise.
Yeah.
So for those patients, you want to tell them, exercise is really important for you, maybe more important than other people.
Yeah.
And then there's other genes that are really interesting, mainly that have to do with the feeling of satiety, feeling full, right? So when you consume food, believe it or not, your fat cells release a hormone called leptin. And leptin goes to our brain and tells us that we're full. It takes about 20 minutes to get there. But many people are leptin resistant, so they can't tell when they're full. So it's a double whammy in the United States today, because most of us, our food is so easy to consume. We don't really have to chew it. It's almost partially digested before it's packaged, before it's served to us. So in 3 minutes, you've consumed a meal of way more calories than you probably need, and your leptin hadn't had a chance to get in the bloodstream yet. So telling people to slow down, and also some supplement recommendations that increase leptin sensitivity can be helpful with patients as well. And there's a few other genes too.
Which really now brings me to the Sydenham approach to incorporating these drugs in the whole program for people, whoever it's recommended for. But you don't rely exclusively on these drugs as one silver bullet, right? For you, personalizing on all prongs, whether it's hormones, whether it's sleep. Can you explain what your approach, personalized medicine approach to weight loss is, while you do incorporate these new age drugs, but it's not a silver bullet, and how everything is important? And you have people we have members who've renewed for 3 years in a row, right? And you have experience of people using them off, on, whatever. I don't know how you design their different protocols, but can you elaborate on how it really works practically at the clinic? What happens?
Right. Well, a lot of negative things have been said about these medications. But I think that a lot of that is because they've not been used the way they really should be used. And part of this goes back to when these drugs were designed, clinical trials were run, and in order to have a homogeneous population so that you can compare results, they would choose a dose, okay? So they would give one dose of this medication across the board to everyone in the trial, the entire cohort, as they would call it. Well, a lot of times that dose was pretty high. So what I've found is with these medications, if you start very low, then patients have fewer side effects. And if you weigh them regularly, and we use an in-body machine, as you're aware of, so when you come in and you're weighed, we're not just looking at your weight, we're looking at your skeletal muscle mass and all different segments, arms, legs, individual, right arm, right leg, left leg, core. We look at your visceral fat, how much fat is wrapped around your internal organs, because that tends to be inflammatory. We look at your percent body fat. And so we monitor that, because the last thing we want to have happen is to have someone start a medication like this and to lose a bunch of weight and have it all be muscle mass. So every time we see the patient, we're looking at their muscle mass, looking at their visceral fat level, looking at their percent body fat, and encouraging them, you know, you must work out. Look, you're losing muscle mass in your legs, you're losing it in your core. You must get in the gym. And it explained to them how important it is for carbohydrate metabolism to have muscle bulk, because that's where your carbohydrates go. And then, of course, we're doing a significant in-depth nutritional evaluation on the patients. So nutritional education is so incredibly important. Many people feel like they are eating a healthy diet, but they really don't understand that they are not, that they're consuming too many carbohydrates, usually almost always too many carbohydrates, not enough protein. And I think the other thing that we need to realize that most people who have insulin resistance, pre-diabetes, obesity, a lot of them also have a lot of dietary nutritional deficiencies. It's not only about avoiding things that are bad for you, but it's really important to get the nutrients in that are good for you as well. So those things are really important. And if you achieve your goal of curing your diabetes, your pre-diabetes, which is really, you know, I think the success rate with these medications, if people are compliant, is huge. If you achieve your goal, then where are you if you are not able to change your lifestyle? So we have to give people the tools to understand what healthy eating is, what healthy exercise is, so once we get off these medications, they can maintain the weight loss that they've achieved. And I think that's been a lot of the negative comments that have been made about these drugs, that people will gain the weight back. Well, that's the same with every diet ever known to man. You know, people, the success rate is very low.
Right.
One thing about these medications is you can use them intermittently or as a crutch or over the holidays if you need to help with cravings. But I think the most important thing is once you break that cycle of insulin resistance and your metabolism starts working correctly again, it's easier to keep the weight off, particularly if you have the tools that you need and the education that you need to realize what you should be eating and what you shouldn't, and exercising also.
Yeah. I also think that there's another aspect that's important. It's the physician-patient relationship, right? You know your patients. You really, like, you have the luxury of time to spend with them. Some patients, you know, say they've tried everything, but they've not tried everything. Some patients may be going through a very stressful crisis in their life where they're, you know, binge eating, or they're not able to control their diabetes because of those reasons. Can you talk about how just knowing the patient and being able to personalize all other aspects of their health, and you don't just medicate them in isolation, you know, how you incorporate that? Can you, like?
So I think a lot of that personal relationship is being able to encourage people and to show them real data, like we get with their lab tests and their in-body, the weigh-in on the special machine that we use. It's that, but it's also taking the time to educate people and to explain to them, because it's a lot of information. Like understanding how all these things work together, your genes, your sensitivity to saturated fat, maybe your sensitivity to carbohydrates, your risk factors for diabetes,
your hormones,
like how all those things fit together. It's hard for me to get my head around. So you can't do that in 15 minutes. You know, this has to be a conversation that has to kind of cover the same things and different aspects of it that you build on, and you build on that relationship with the patient. And it's when they really understand and they see results and they start to understand how it all fits together that I think it really brings them, that's the real value. That's when you really make the breakthrough.
And I think you got it. Like, we're looking for that breakthrough, right? And a lot of people will get their hands on these drugs through, I don't know, through different doctors who are not their primary care doctor, right? And I feel like they're missing the whole point, right? They're missing the whole benefit of how you will analyze the root cause. Like, you know, why are you obese? Or why are you pre-diabetic, right? Like, that's a starting point for you.
Yeah, I think that's true. I think it's very important that that these medications are used appropriately. And I think it's really a shame if they're not being used appropriately and there are bad outcomes, that I don't think we should throw the baby out with the bathwater. I mean, we're seeing now reduction in heart disease has been found, non-alcoholic fatty liver disease. I've seen patients' liver enzymes. I have one patient whose liver enzymes have not been normal for 20 years because of fatty deposits in her liver. Treating her prediabetes with these medications, they've normalized. So this is a big breakthrough. I mean, that's a huge problem now in medicine, is this non-alcoholic fatty liver disease. And so, you know, stroke risk, I think, has been found to be reduced. So this ability to kind of fight back against this overnourishment that so many people are suffering from it's been a big breakthrough. And I think we should really see the benefits of these medications.
And you mentioned earlier that alcohol cravings reduce, so people struggling with alcoholism, alcohol. Also, I hear you talk very often that when these people go on these medication, you keep encouraging them not to drink their calories. Can you talk about that?
Because a lot of the mechanism of action is based on this feeling of being full. And when you use these medications and you eat, you often feel full sooner and you feel full longer. Particularly with Zeptide, Mounjaro, patients will tell me, I'm hungry, I sit down to eat, and I've had a few bites, and I'm done. I'm full, you know? If something is working based on your feeling full, then if you're drinking liquid calories, you never feel full. It just goes right through your system and right into your bloodstream. So that's kind of the way to short circuit these drugs and to get around them, is to drink your calories. And of course, you can drink a lot of calories in wine. You can drink calories in milkshakes. You can drink calories in anything, you know, sugary sweet drinks. But yeah, that is a way to kind of thwart the effect of these medications. Yes.
Well, thank you. I think this conversation was quite enlightening for some people who are dying to start this medication, or if they're scared to start this medication, because sooner or later, it's going to be a part of our lives, right? We will have a family member who is on these medicines. And I think with the kind of experience that you've had, you know, more and more reasons are alluding to the fact that you should be allowed to treat other things for something, you know, which can be life altering, like you can avoid stroke, you know, you get rid of alcoholism, fatty liver disease. So I think there'll be more indications for prescribing these drugs as we go along. And the more we educate ourselves about it, the more we know about it, is good. And more importantly, you know, the supervision and the whole holistic, personalized approach to incorporating these new age medicines, I think, is where medicine is going today. Before we end, like, can you sum up just the personalized medicine approach to lifestyle change? Because, you know, weight is a very big factor it's like a baseline factor for other diseases, right? And how it's a big component of when we say lifestyle change, it always involves maybe regulating your weight. So if you can just talk a little bit about the Sydenham approach and the personalized approach that we take in the whole lifestyle change.
So what we try to do is take a very holistic approach to medical care, utilizing tools that are available to us, but in many cases they're not paid for by insurance companies, so they're just not, you don't see these in the regular doctor's office. But we use a combination of genomics, which I think is a huge, huge breakthrough, because this is telling us not that you have a genetic illness or you don't, it's telling us about how your metabolism works. And I think that's really, really important. That's some of the fat obesity genes I was talking about. But this is multiple, 33 different categories. I think heart disease, stroke risk, cognitive decline risk, cognitive decline later in life, risk factors for certain vitamin and mineral deficiencies that people aren't aware that they have. So the genomics in combination with the hormonal analysis, which is very important in women, how we metabolize our hormones, what our levels are, really a deep look at that is important as well. Then the nutritional approach, where we're looking not only at the nutrition that you need and what you're getting, but also spending a lot of time looking at the fecal microbiome, because now we know that our immune system is trained by our gut. And then focusing on sleep. All of our patients have an Aura ring. So that's just a cornerstone of wellness. And then also looking at exercise and that, which is so important that you get it in some format, and really in multiple formats. You know, really we all need to have flexibility, strength, and some aerobics as well. I think the thing about the Sydenham method is when you put all that together for the patients and help them understand how these things work together, it becomes so much more meaningful to them than just trying not to eat French fries and trying to go to the gym. You know, when you understand how it works, and the trans fat and the French fries and the carbohydrates and the insulin and the insulin and how it pushes the glucose into the muscles, and why it's important to have strong muscles so you can consume these carbohydrates and your body can utilize them. It's just one of many aspects of how the whole body works together, and it's incredibly fascinating. And when it becomes meaningful to people, then they change their lifestyle because they get it. I think it becomes fun.
It becomes fun, right? And it becomes normal. And that's bringing me to the last section of our podcast, because not only did you develop the Sydenham method, but you lived this lifestyle. And you probably lived the opposite lifestyle because you were an ER doctor, right? Yes. So can you talk a little bit about how and why you developed this method, and what was going wrong with, you know, traditional medicine or modern medicine? And
I would say I have been in practice since 1984, and what I've been seeing is one patient after another as fast as I can. And as I've practiced through all these years, I've seen medicine become more and more fragmented. And my last position prior to coming here in the MD Anderson ER, which is a fabulous institution, I think it's the best place in the world for cancer care, no doubt. But even there, patients might have 15 different physicians, all taking care of one body part and one specialty. And there's not enough communication between those physicians, and the patients are confused and they're frustrated. And so what I love about what we do here is we try to bring this together for people. So we try to bring it together so they understand how things work, and bring it at least the center of control under one roof.
Yes. So before we end, we ask all our guests this question, that what is your secret sutra for your life?
Okay, so my secret sutra would probably be never stop learning, and always keep in mind where we are on the human timeline. So I feel like many people feel like, oh, we are 2023, we know everything. But we have to understand that our knowledge may not be very full, just like it wasn't 100 years ago. So we have to realize that there's so much more that we don't know. And I try to keep life in perspective that way.
Well, thank you for explaining that. And thank you for a fabulous, one of many. They're going to be seeing a lot more of you, because at Ask Sid, the whole point is we want you to send in more questions and more topics so we can have our fabulous medical team unpack those for you. Because like Dr. Rice said, educating people is a very big part of really getting the impact, the breakthroughs that we're hoping for. So while Sydenham is here to help you with your weight loss goals, or to reverse diabetes or that fatty liver disease you have, stay tuned and ask us more questions. And remember, health is by choice, not by chance. Until next time.